Good afternoon, everyone. Thank you very much to Fertility and Sterility Society of Bangladesh, who has already invited me to this very wonderful meetings. On my presentations, I will talk about international evidence-based guidelines, especially the role of insulin sensitizer in PCOS. We know that in anovulatory women with polycystic ovaries, the antral states of the follicular development are clearly abnormal, and growth of these follicles is typically arrested at a diameter between 5 to 8 millimeters. Why it happened in PCOS? One of the etiology is insulin resistance. In these situations, there is a hyperinsulinemia that will induce decreasing production of sex hormone binding globulin by the liver, and it will lead to increasing free androgens intra-ovary that will arrest follicular development in the ovary. Women with PCOS are under chronic inflammatory state in the long term and may have increasingly risk of PCOS mediated by upregulated androgens, insulin, inflammatory cytokines, and downregulation of adiponectin, and also sex hormone binding globulin. Clinical manifestation of PCOS is quite varied. We know that natural history of the PCOS, they likely has long-term effect, starting from fetal life, adolescence, childbearing age, menopause, and post-menopause. Both of infertility and irregular menses are the most likely clinical manifestations during adolescence and childbearing age. And international evidence-based guidelines for the assessment and management of polycystic ovary syndrome in 2018 was led by Center in Research Excellence in PCOS, Monash University, American Society for Reproductive Medicine, and ESRI has already launched the new guidelines how to manage PCOS patients. The two most controversial issues in management of PCOS patients, such in diagnostics and treatment, insulin resistance, and also the use of insulin sensitizer in our daily practice. And international evidence-based guidelines for the assessment and management of PCOS consist of screening and risk assessment, lifestyle management, diagnostic assessment, medical treatment, and infertility management recommendations for us in the clinic. This is the first recommendation regarding the screening and risk assessment. We should be aware that regardless of age, the prevalence of gestational diabetes, impaired glucose tolerance, and type 2 diabetes are significantly increased in PCOS, with risk independent of and yet exacerbated by obesity. The increasing up to 5-fold in Asia, 4-fold in America, and 3-fold in Europe. Therefore, 75 grams of GTT should be offered in all women with PCOS preconception when planning pregnancy or seeking fertility treatment. Health professionals and women with PCOS should be aware of a 2 to 6-fold increased risk of endometrial cancer. However, absolute risk of endometrial cancer remains relatively low. How about lifestyle and pharmacological? Healthy lifestyle behavior encompassing healthy eating and regular physical activity should be recommended in all those women with PCOS. In combination with COC, metformin should be considered in women with PCOS for management of metabolic features, where COC and lifestyle changes do not achieve desired goals. In combination with COC, metformin should be considered in adolescents with PCOS and BMI above 25, where COC and lifestyle changes do not achieve desired goal. How about the role of medicine? In combination with COC, metformin, in addition to lifestyle, could be recommended in adult women with PCOS for the treatment weight, hormonal, and metabolic outcomes. And for infertility management, metformin could be used alone in women with PCOS with anovulatory infertility and no other infertility factors to improve ovulation, pregnancy, and live birth rate, although they should be informed that there are more effective ovulation induction agents. CC could be used in preference when considering CC or metformin for ovulation induction in women with PCOS who are obese with BMI more than 30. If metformin is being used for ovulation induction in women with PCOS who are obese with BMI above 30, CC could be added to improve ovulation, pregnancy, and live birth rate. Clomiphene citrate could be combined with metformin rather than persisting with clomiphene citrate alone in women with PCOS who are clomiphene citrate resistant. And as the second-line drugs, gonadotropin, where available and affordable, should be used in preference to CC combined with metformin for ovulation induction in case of CC resistance. This is our study in Jakarta trying to see the correlation between serum AMH and HOMA insulin resistance among PCOS phenotype. And we found there was a positive correlation between serum AMH and HOMA insulin resistance levels. Serum AMH and HOMA insulin resistance levels were significantly different across the 4 PCOS phenotypes, with the highest values were present in phenotype 1. This table showing us hormonal characteristic based on Rotterdam criteria for PCOS patient, and we look that in phenotype 1, AMH is the highest level, 11.7, and also HOMA insulin resistance in the highest level, about 4.2. So phenotype 1 shows significant higher AMH level than other phenotypes, and also significant higher HOMA ER other than other phenotype. Our study shows significant difference in fasting insulin and fasting glucose level among the 4 phenotypes. As we can see in this figure, this is the fasting insulin across the four phenotypes and the fasting glucose across the four phenotypes. In the current study, we found an association between AMH and insulin resistance with coefficient correlation is 0.52, and this is significantly different. The other study trying to see how the effect of metformin and bioactive fraction of cinnamon towards serum AMH in women with PCOS. This is a double-blind and randomized control trial. And we found that there was a significant decrease in the serum AMH level after administration of insulin sensitizer, both metformin or cinnamon. We randomized 51 subjects to receive metformin or DLBS 3233. This is cinnamon. And each group consists of 20 and 18 subjects. For both groups, there is no significantly different patient's characteristic, including age, PCOS phenotype, baseline BMI, HOMA-ER, and also baseline AMH level. And after 6 months of the treatment, the post-treatment AMH in both of groups are significantly declined, especially for metformin group. This is a significantly different before the treatment of insulin sensitizer. And in metformin group, among 20 subjects, we found 5 patients conceived spontaneously within 6 months after they received metformin. And it was shown that the serum AMH is significantly lower after receiving insulin sensitizer for 6 months. It means that after receive insulin sensitizer, AMH level decline significantly, and the process of folliculogenesis is starting again because AMH are suppressed indirectly by insulin sensitizer. For the other group, the role of cinnamon, we found 2 patients conceived spontaneously, and also there's 1 patient serum AMH was declined significantly after 6 months of treatment, cinnamon. And again, this shows us that insulin sensitizer has the role for suppressing AMH level in PCOS patients. The last study about the role of cinnamon in the management of PCOS patients, again, this is a randomized, double-blind, and non-inferiority clinical trial compared to metformin. We'd like to evaluate clinical and metabolic efficacy, and also evaluate the efficacy of cinnamon in improving reproductive parameters and the safety of cinnamon in PCOS patients compared to metformin. We enrolled 124 subjects divided by 2 groups, and then complete 34 and 39, and available for intent to treat analysis, 52 in cinnamon and 54 in metformin group. Both of groups saw us the significantly decline ratio between stroma and areas of cortex in the both of ovary, and also show declining of BMI and waist circumference. Even we can see here the metformin group has lower BMI and also lower waist circumference, but both of groups show the significantly declining of both BMI and also waist circumference. And for menstrual regularity rate, this is for intent to treat and also per protocol analysis. And after the treatment, the regular menstrual cycle improving significantly, yeah, from about 1.6 and 33.3% up to 14 and 16% regular menstruations, and also in the per protocol analysis. So the insulin sensitizer improving also menstrual regulations in both of groups, whether use metformin or cinnamon. And this is the pharmacological treatment for non-fertility indications. We know that we could consider in adolescent with PCOS and BMI more than 25, the COC plus lifestyle plus metformin could be considered, and most beneficial in high metabolic risk groups, including those with diabetes risk factors. And metformin plus lifestyle, most useful in the group with BMI above 25 in high-risk ethnic groups. And metformin appears safe long-term. There is no problem issue with metformin. And then for the treatment of infertility, metformin still in the first line, could be added in CC, especially for the CC resistance. And metformin alone actually is not as effective compared to CC alone. And as a take-home message, for non-infertility management, we know that prevalence of gestational diabetes mellitus increasing in the PCOS patients. So therefore, OGTT should be offered in PCOS during preconception. Combination with OCP, metformin could be considered in adolescent with PCOS and BMI above 25. And this should be considered metformin for the management of metabolic features. And metformin in addition to lifestyle could be recommended in adult women with PCOS for the treatment weight, hormonal, and metabolic outcomes. For the infertility management, actually metformin could be used alone. However, there is an ovulation induction agent could be more effective compared to metformin alone. And CC could be used in preference when considering CC or metformin in women PCOS who are obese. And the CC resistant metformin can be combined in the with CC in the CC resistant in number 4. I think this is my presentations. Thank you very much for your kind attention.